Anne, thank you very much, and I want to thank BlackRock. But as our panelists are coming up for our first panel on Sex in the City, the impact of urban life on women's health, I wanted to just begin by first thanking President Gutman and Dean Melise for their vision, for their passion for women's health, and for their partnership with the School of Medicine and the School of Nursing. I think this is really, we've set a precedent here, and I am just delighted to be able to work with two phenomenal, extraordinary women, so thank you. As the moderator for the first panel, I have to do some housekeeping. So what I would like to tell you is that at each table we have cards, and we really do want this to be an interactive session, and we want to hear from you. So it may be easier as you listen to our panelists or that you write questions down on the cards, one question per card, and we will have volunteers roving the room that will pick these up. And if you want to put your email on the back of the card, if we don't get to your question this morning, we actually will get back to you via email, or there are several opportunities for you to follow up with this conference through the Penn Urban Women's Health Facebook page. That's the social networking President Gutman was talking about, and also the Penn Urban Women's Health Collaborative eCommons website. So we do want to begin the dialogue today, but we don't want to stop it. We want to continue it. We want to gain momentum this morning. So I hope that you will take advantage of those cards. Now, what I'd like to do is to introduce our panelists, and each of them will spend about 5 to 6 minutes sharing with you some of their experiences. We're going to talk about the impact of the urban environment on women's health. We actually have a unique opportunity this morning to look at adolescent health care, maternal health care and infant health care, and also the elderly. So I think this is a fabulous panel that we've put together. We have Ruth Lubic. Ruth is the founder of Family Health and Birth Center. She is the founder and president emeritus of the Developing Family Center, a recipient of a MacArthur Fellowship. Anne Teitelman is an assistant professor at Penn School of Nursing, and Marie Savard is an ABC News medical contributor, and both a nurse and a physician. So what I'm going to do is I'm going to ask, we're going to jump right into the panel this morning. I think we have fabulous introductions, so I don't want to restate the obvious, is that urban environments do negatively impact women's health, and we need to do something about it. And I think we'll start with Ruth Lubic this morning. Ruth?
Thank you, Debbie. My contribution to this panel is rooted in my work as a nurse midwife to improve maternity care for all families through the community-based, and community-based is very important now, freestanding birth center model initiated in 1975. My contribution is also related to my intent to reduce infant mortality in this country, which is especially high among African American families. The dismal statistical showing of the USA in infant mortality among the developed nations of the world, I think it's 29th, has long been on my professional conscience. The more horrendous results are in our cities, especially our nation's capital, at 12.22 infant deaths per 1,000 live births. New York City's rate is 5.3 per 1,000 live births, and our honored guest, Nicholas Kristof, in his recent column cited a figure of 2.9 infant deaths per 1,000 births in today's Shanghai, China. Is there something there for us to learn about global health? When in 1993 I was fortunate enough to receive a MacArthur Fellowship, the so-called Genius Award, I was able to turn my attention from a birth center established in the South Bronx in 1988, and with my husband's support. that means emotional and financial. Take up the cause in the District of Columbia. You may stand, Father. The Bronx experience had demonstrated the empowerment and increase in self-esteem which resulted when low-income families were encouraged to take charge of their own health by the midwives. A new model, the Developing Family Center, was incorporated in 1998 in DC's Ward 5, which is a low-income African-American, mainly African-American ward. And after extensive renovation of a donated long-vacant Safeway supermarket, it opened its doors to provide services in October of the year 2000. The DFC is an innovative, collaborative project to provide services to childbearing and child-rearing families, with special attention to reducing the disparate maternal and infant outcomes suffered by low-income African-American families. With the assistance of 3 service-providing agencies, one of which is the Family Health and Birth Center, families receive and participate in care according to their needs rather than the needs of an organization. Health care provided by nurse midwives is available from preconception through maternity care, the breastfeeding experience, and on into gynecology for the mothers, and pediatric care is provided by nurse practitioners through the infant child's life from birth to age 21. In addition to the birth center, 2 other nonprofits are housed in the same building. They are the Healthy Babies Project, an education, social supports, and case management agency, including home visiting, a program for teens and fathers groups, and also the other organization is the Early Head Start Center of the United Planning Organization, and children from 6 weeks to 3 years are taken care of there. Backup medical services are available when needed through the Department of OBGYN of the Washington Hospital Center, where the nurse midwives have admitting privileges. Although about 70% of the women need hospital birth, the same midwives who provided their prenatal care attend them as they labor and give birth there. They are not delivered unless they have a section. Then they're delivered. But for the most part, that's a big difference between midwifery and the medical model. The disparities usually suffered by African American families have been reduced substantially in this nurse established and run project. In the year 2006, for example, the major precursors to infant mortality, preterm birth and low birth weight infants, were much reduced from the experience of African American women in the district overall, by 2/3 for preterm birth, by 4/5 for low birth weight infants. Cesarean section was reduced as well by 2/3, resulting in lowered costs to the healthcare system of $1,635,248, a figure greater than the operating budget of the birth center in that year, and that was done on 153 births. Although we struggle with reimbursement of just half our charges coming from the for-profit Medicaid managed care companies. But if all Medicaid-supported births in this country were managed in this way, billions of dollars could be saved. Thus, the DFC is setting health care in its social context and often is described as a one-stop shop in that the 3 service providers are housed in the same building, eliminating the need for families to shop the entire city for referral services. The above results demonstrate the DFC's ability to reduce the so-called intractable disparities of infant and maternal mortality and morbidity often suffered by low-income African American families, while at the same time raising self-esteem and enhancing their parenting and family skills. It is the judgment of the founder, moi, that the improved outcomes in preterm birth, low birth weight, and cesarean section are made possible by the application of a midwifery model of care which focuses on provider-client relationships and on reproduction as a normal event rather than one fraught with danger and need for technologic intervention. The midwifery model also respects the needs of families for information about childbirth and child rearing and does not restrict the time of visits when help is needed. The maternity experience is seen as touching on the social and emotional aspects of family life as well as the biological needs of the expectant woman. This is not rocket science. It is a model which emphasizes treating women and families like fellow human beings. Thank you for the opportunity to speak.
Hello. I'm so glad to be talking with you today about girls in our cities, their sexual health, and relationships. And yes, I'm going to be talking about sex in the city. First, I want to situate our urban girls who are living in the decaying sectors of our cities with loss of industrial jobs, generations of discrimination and poverty, within urban families that are fragmented and yet resilient, in neighborhoods where they are surrounded by violence, where young men cannot find jobs but can find work in the underground economy with incarceration and death as occupational hazards. Needless to say, girls growing up in these physical and social environments have limited choices, opportunities, and compromised health and safety. In my research, I start by gathering the stories of girls and young women. This is the story of Gina. He was chasing her for a year from the age of 12. And then at 13, she finally gave in and she fell in love. He was 19. She wanted to use condoms, but he told her that she was his girl, and so she should not worry about using protection. Also, when he hit her, she thought that showed how much he liked her. At 14, after the baby was born, she still wanted to be in a relationship with him, but after a while she found out she had gonorrhea, and she gave up on him. Now, at age 24, Gina thinks what might help young girls like her would be a place where girls could gather together with some trusting adults, maybe fix up an abandoned house and meet there, because when she was young, she didn't have anyone to talk to. Gina's story echoes through our cities. In the U.S., overall, less than half, 46% of high school-age girls have had sex, but in some urban areas, almost 60% have had sex. Some research indicates over half of urban adolescent girls who've had sex have male partners who are 2 or more years older, and this is associated with increased sexual risks, such as unprotected sex. Adolescent girls across the U.S. experience rates of teen dating violence victimization of approximately 9%, with urban girls reporting twice the national average. And these are nationally represented statistics, but probably a gross underreporting. Within cities, partner violence is most prevalent in low-resource communities, especially in neighborhoods of poverty and in households of economic distress. Thus, adolescent girls often have less power in their relationships and are therefore at a disadvantage in safer sex negotiations. This might explain why adolescent females aged 15 to 19 have the highest rates of gonorrhea and chlamydia compared to all other ages, both male and female. And gonorrhea and chlamydia, while they're easily cured with antibiotics, often most infections in women have no symptoms, and if left untreated, can result in devastating consequences of infertility and ectopic pregnancy, while serious health consequences are much less common among men. And also, our young African American women face significantly higher rates of gonorrhea and chlamydia than any other group. This is the story of Erica. She was 14 when they met. He was overprotective, and that made her feel safe in the neighborhood where there was a lot of violence. But he wanted to control almost everything, and yelled at her a lot, and sometimes grabbed her during arguments. She carried condoms with her and made him put them on, but he would take the condom off in the middle of having sex. That's how she got pregnant. Also, she had long suspected he had other partners. However, after she found out he had given her a sexually transmitted infection, she didn't want to talk to him and didn't want him to touch her, and he got mad and forced her to have sex. Now at age 22, she says she thought the arguments with abuse was the way it was supposed to happen, since that is what she saw around her growing up. She thinks teen girls need to know that healthy relationships involve trust and respect. They need to understand the warning signs of an abusive relationship and need supportive adults teaching groups of girls. Erica's story is not unique. In the U.S., 10% of high school-age girls have experienced forced sex, with urban girls reporting rates closer to 13%, again, probably a gross underreporting. And half of girls diagnosed with a sexually transmitted infection or HIV report a history of physical or sexual partner violence. In fact, across the U.S., 12% of HIV infections can be directly traced back to partner violence. The majority of adults and adolescents diagnosed with HIV infection in the U.S. reside in metropolitan areas with populations of 500,000 or more. And in some of our cities, they have 5 times the rate of HIV compared to national statistics. In the U.S., sexually transmitted HIV infections among young people are increasing at alarming rates, especially young minority girls and women. And HIV is now one of the leading causes of death among young adult women, likely infected during adolescence. So what does all this mean? When an adolescent girl is held back, that ripples through all of society. But if she can safely navigate through adolescence, not only will she benefit, but so will her family and community for generations to come. So what can we do? One thing my research points to is the need to provide girls with effective interventions and create safe spaces. So my research team and I are creating an advocacy and empowerment intervention for adolescent girls called Stand Up Together, in which we work with them on the knowledge and skills they need to prevent HIV and other sexually transmitted infections, as well as recognizing and avoiding unhealthy relationships and learning how to build healthy relationships. But that is one small step that needs to be part of a comprehensive approach to giving our urban girls more choices and opportunities and fostering resilience. We need to continue to revitalize our urban communities, make them safe places to live and work and learn, and promote gender equality within them. And these issues are global issues as well. In a recent trip to South Africa, I talked about our urban adolescent girls here in the U.S. with our colleagues in Pretoria, and they were struck by how similar the issues were there. At the level of social policies, I'm encouraged by the increasing recognition of gender equality as a fundamental importance to advancing development in cities and around the world. For example, in the U.S. Global Health Initiative launched by President Obama in 2009, a focus of women, girls, and gender equality is one of 7 core principles. And also, as you heard, United Nations Secretary Ban Ki-moon has made women and girls equality one of his 8 major platforms and supported the creation of UN Women. We are at a moment of exceptional opportunity. I feel like now is the moment to act. And as the way forward, as I quote from a report called Girls Speak, if you want to change the world, invest in an adolescent girl. Thank you.
I think as we're hearing, and as we all probably have experienced, women consume a large amount of health care in their lifetime. They share a larger burden, perhaps, of illness in their lifetime. And furthermore, they are the ones that make most of the medical decisions for their family members, for their loved ones, for their elders. And they are the caregivers, there's no question. But with that said, I would argue we can use the commonly sort of quoted phrase, I'll change it a bit, teach a woman how to manage her family's health, or teach a woman to fish, let's say, which means manage her family and her loved one's health. And you will teach the world how to take care of themselves forever. It's not about just giving a woman health care, which is a very passive thing, which means great, she's in good health for a moment. So I think remember that. This conference today is about not giving a woman a fish and feeding her family for a day. It's about truly teaching her. We know, actually, in terms of health literacy, for example, there was just an article in the Journal of the American Medical Association this week looking at issues around health literacy and pointing out that with a simple questionnaire identifying those, even with health insurance, they were Kaiser-insured women and men, that those that had poor health literacy actually had much poor health outcomes, increased death, and in this case it was looking at heart failure and heart failure hospitalizations. So as one simple solution, just even asking the question around health literacy in our urban areas where it's a big issue and for which we as physicians often we don't even think about. We can talk later about what some of those easy questions were. But let me remind you, when it comes to educating women and teaching women how to manage their family's health and make wise decisions, both economically and in every way, we have to realize that there are over 126 medical schools. There are how many, umpteen numbers, maybe Afaf knows how many nursing schools that teach practitioners how to be practitioners. Yet there are no schools, really, that teach patients, that teach women how to manage their own family's health. And it is becoming increasingly complicated and increasingly important in this very fragmented, reduced access healthcare system that we have, that is going to be ever more challenged in the future. There's no question. So actually, I've spent a large part of my life, it really started in 1995 after the Women's Conference. I had the good fortune of going with the World Health Organization as their technical advisor. And it was then that I understood for the first time it wasn't just about women's health issues. I cared about menopause and hormones and what's the latest research on Pap testing or whatever. But it was really about empowering women in all aspects, economically, politically, and in regards to their health care. And when I came home, it was then that I sort of branched out and really developed what I called a patient power school. And I think now we need to change it to kind of women power or female power or whatever. But I've actually worked in developing a program that was based on something that I learned in the 1970s, research that was done that I think really got pushed aside. But we need to think about what were the three elements. This was part of a study that was done in Massachusetts through what was referred to as the medical outcomes study. And they showed in the 70s and 80s that if you did three things, you could reduce healthcare costs, reduce hospitalization, and help people manage their health better. And those three things, first was they used the word activate patients. I would use the word empower. We use that word now, and we understand what that means. They taught people to speak up, to have a voice, to not be afraid of the doctor, God forbid, or the nurse or nurse practitioner. And they did that with very simple coaching, 30-minute period of time. The second thing they did was actually give the patients, each one, a copy of their medical record, their vital information. Arguably, who owns that medical information owns the power. And that's part of the program, teaching people how to control their own medical information. And the third thing they did, and believe me, we didn't have great evidence-based guidelines in the 70s and 80s, but we were beginning, and now we have much better and need to get even better. They gave them a copy of whatever that evidence-based guideline was at the time, and in that case it was kind of expert-based or sort of community-based, but whether it was asthma, high blood pressure, et cetera. Those three elements are kind of the core of what this Patient Power School is all about. And I've had the good fortune in West Philadelphia, for example, to implement this among university high school students who were disadvantaged, and it was extraordinary what happened. But just some quick elements. First is truly telling people. When I speak to audiences, it's unbelievable. Sophisticated audiences need to hear no one cares more about your health or your life than you do, or your family's life. That, we too much sort of believe in that trusted physician. We have to remember Marcus Welby is dead. It is about us. We really have to step up to the plate. So empowering people. Second is the idea, and I never leave home without it, and I won't ask you if you've left home without yours, but the idea of keeping your trusty health information. Something as simple as having a woman take ownership for her family and for her loved ones, for her seniors. This thing saved my father's life. I can't tell you how many times. This was a voice for him. It had his list of medications, allergies, diseases. Oh, yeah, some of you are thinking, oh, well, don't we have a little smart chip we can put under the whatever? Or, I've had pushback by physicians saying my patients will be too lazy to fill this out. No, this empowers. And women will do this. Young kids, teaching them in the schools, will do this. And yes, our technology will be such that the kids will be beaming it to each other on their smartphones and on their Facebook pages, whatever. Let's have a conversation. This is so important. When Katrina happened, I was interviewed so many times about the fact that physicians didn't have even the simple health information like medical records. Can you imagine what's going on in Japan and perhaps even in Alabama? So that's another component of it. A third component is the notion of having a health buddy. Don't ever go it alone. We're always going to be vulnerable as patients. When you have that important office visit, take somebody with you. Take your loved one. Take your seniors. Don't just drop them off on paratransit. Go in that exam room, because everyone loses their personal power when they walk into that office. And again, I say give your doctor a self-addressed stamped envelope or your nurse practitioner and say you want copies of those records. So those are just small components. But the bottom line is this is really about educating, I think, women first, and women will pay it forward. And they will educate their children and their children's children in time to understand that it's all of our jobs. The future is about managing chronic disease. Yes, we're all going to have those motor vehicle accidents and those terrible things that require completely passivity as a patient. But for the most part, the burden of health in the world is about chronic illness. And it's those things that we need to empower women and ultimately families and communities about. I'd kind of like to end on, I have two wonderful quotes I'd like to share with you. First is what I say to fellow physicians when I speak to them. And they're looking at me askance, like, how dare we educate patients that much? And you would be surprised. I get some amazing feedback, although it's changing. And it will change as we have more and more women, I believe, in healthcare. But I remind them of the words of Albert Schweitzer, who was the missionary physician to his fellow physicians in the countries of Africa in the last century. And he said, each patient, and I will paraphrase, each patient has his own doctor inside him or her. She comes to us not knowing that truth. We, as physicians, as practitioners, our job is to recognize that physician inside each person and give them a chance to go to work. And I would argue to physicians, it's our responsibility to recognize the power of each individual patient to know and chart their health destiny, and it's our job with literacy issues, et cetera, to pay it forward. And finally, a challenge for the conference today is from a science fiction writer, Ursula Le Guin. And she says, as a woman's real power grows and her knowledge widens, and that's our job, ever the way that she follows grows narrower until at last she does nothing but wholly that which she is meant to do. Our job is to give women knowledge and power so that they can move forward doing exactly what is right for her family, for herself. Thank you.
Well, I want to thank each of the panelists for that nice introduction, but I must tell you, I have great questions here, so we're going to move right to the Q&A. And I'd like to start by asking a question, directing this towards Ruth. Ruth, you described a success story, and have other cities replicated your model? And if so, how do they get funded? And if not, what's being done to develop similar programs in other urban areas?
There are many birth centers around the country, freestanding birth centers, about 200 of them. And there is an organization for birth centers, and there is accreditation for birth centers, as well as licensure for them. So, but that all started in 1975, so it's had a few years to go. The Developing Family Center is well recognized as being, yeah, this is what we need to do. We get lots of visitors in Washington, and by the way, you're all invited to come when you're in DC to come out and see us. I have a few cards if you'd like. But the replication is a problem. Our survival is a problem because of Medicaid managed care. And what I'm spending my days doing is trying to convince the Centers for Medicaid and Medicare Innovation to make what we're doing a pilot. Now, it's not only around the country. There must be 50 or 60 places around the country that want to replicate what we're doing. And in fact, Congressman Cohen from Memphis tried to replicate in Memphis and was unable to carry it through. And he introduced a bill, but that's gone by the board now. But just a week or so ago, we had a group from Ghana coming. They want to replicate what we're doing. At that symposium that I mentioned to you on midwifery, which took place in Washington last June, there was an honor given to the work of what we're doing, and it's attracted a lot of attention. The World Bank has sent staff to visit us. I could just go on and on about the high level of interest and the lack of negativity about what we're doing, because people understand that if we don't target the families that have experienced these terrible disparities in care, then we'll never win the ball game. And that's why I'm in Washington, and that's because Washington has the worst outcomes. But I need the help of each and all of you to get to people who will listen to us and try to help us make this kind of care more available. And the fact that we're saving lots of money, well, I guess I might say that when you save it, that means somebody else isn't getting it who got it before. So anyway, that's my story.
Anne, the statistics on violence are really staggering. Andrea Mitchell mentioned globally 1 out of every 3 women has experienced some form of violence, and it often begins in young girls. What can we do? What kind of programs do you think would be effective in addressing this very important issue?
Well, I think it's really has to be a multifaceted approach at many different levels, and working directly with girls is certainly important, but in addition to that, we need to work with boys and young men. One important program that is being launched from the Family Violence Prevention Fund is a program called Coaching Boys into Men, which is delivered through coaches in the community. I think that we need our design colleagues to think about how cities are laid out and structured in terms of sidewalks and lighting and transportation that's safe and convenient and affordable. I think we also need to encourage policies that provide comprehensive sexuality education in the schools, coupled with relationship education, coupled with gender education. And that should be something that starts from very young ages, and there should be a lot of dialogue about that in communities. I think making it a priority in policies and in research. I know that it's, as a researcher, sometimes violence isn't seen directly as a health issue, believe it or not, in the research community, and that needs to be, those connections need to be made very clear for NIH, for instance. I think as many places that there are problems, there are also solutions. So we need everybody's help in making this a safer world.
I'm going to open this up to the whole panel. We have women and men in this audience who have children and might even have grandchildren. What practical advice can you give them about discussing these issues or approaching these issues with their children, with their families?
Well, I always think being role models first and foremost. So what children see in the home really matters, and treating each other with mutual respect. So I think it's first something that we all need to question. Do we treat everyone with a sense of fairness and with respect? Because that's where it starts. And I think it just has to resonate out from that. It's all of us being more courteous, or in just simple ways, giving everyone a chance to speak or to listen. I think we can just create an environment where it's just as we have a whole issue around bullies right now, let's have an issue around, let's bully or let's ignore the perpetrators. You know, let's have our behaviors not negative towards the perpetrator as much as away from, and just in a very positive way. I think it's just our own actions that are as powerful as anything.
So I'll direct this towards Marie. There are many issues that face older women, and particularly in the cities where we see staggering rates of obesity. In some of the poor areas in Philadelphia, for example, over 70% of the women are obese, and we are seeing increasing rates of diabetes, increasing rates of cancer. Are these issues unique to urban areas? And then what are some of the potential solutions or concerns that you have for women, baby boomer generation and beyond?
Well, I think you've hit the issue that really is the issue of our times, and that is around the consequence of obesity, the rise of diabetes throughout the world, and ultimately then the rise of heart disease, heart attacks. When I was in Beijing even, I remember speaking, and they mentioned that in poor countries, soon they are now going to have heart disease as a leading cause of death, in part because of overfeeding of unhealthy food and highly processed food. What I firmly believe that it has to be a top-down and a bottom-up solution. An example of a top-down is something that's a little disappointing. We read just this week that the Federal Trade Commission came up with voluntary recommendations to the food industry to reduce the amount of salt, sodium, or salt and sugar and fat, for example, and trans fat in the foods. But it's a voluntary recommendation. That's great. And they have 5 years, to start doing this voluntary recommendation. What does that mean? I mean, it took a long time, and I think women were part of it, to get rid of the trans fats in food. Well, guess what? There's still trans fats in food. We know that they're associated with increased risk of heart disease, cancers, all sorts of things, and yet the labels are all advertising 0 trans fats. Well, guess what? Read between the lines. There still are small amounts of partially hydrogenated or the trans fats in the foods. It's just that 1 serving size. So that's back to the education. Teach women to read food labels and to know exactly what they're consuming and be very wary of any processed food. As far as urban communities, there's no question it's access to healthy foods, fruit and vegetables. I don't want to hear one more story in the media. We're always pitching this story, that story, making people crazy about diets. We know what works. We know that a lifetime of fresh fruit, vegetables, grains, the Michael Pollan mantra, as he has said in those 7 words, eat food, he meant real food, not that processed stuff that your grandmother wouldn't recognize, mostly plants, but a little bit of meat and dairy, etc., and not too much. And that's the message for families, schools. I mean, we could go on, but it is the problem, I think, and will be the burden of illness that we're all going to face and we're all going to be paying for the next generation.
So I'm going to, yes, absolutely.
I'd like to add to that because I wasn't able to tell you all the things we do, but for example, we use peer counselors. We have a garden in which the children are taught how to plant and how to harvest. We have a group coming in to show the adults how to prepare food and so forth. So to me, the important thing is it's community-based and that we have gone to the community to ask them what they think would work so that you're empowering them, and then when you find out what they think would work, do that. Listen to them.
So I'm going to ask this question and ask the panel to each of them to comment on this. We are an audience of the privileged. How can we as individuals reach across the divide between us and the women that are living in dense urban blight, in poverty? How can we influence the political will and the infrastructure to better support women surviving against disadvantage? I don't know who would like to start with that question.
I'll start. I guess I was the first one in class who had raised my hand, right? No, I wasn't. If anybody was in medical school with me, they know I wasn't, really. I'm going back to Beijing, and I remember listening to, I think it was, at that time, a group of powerful women. I mentioned it last night. I mean, from Betty Friedan, et cetera. They were all speaking about what we can do. And actually, I was impressed that political action was the most powerful thing we could do. And it meant all of us, and they were challenging us as women. And I was standing beside what was formerly now our Senator Connie Williams from Philadelphia, my good friend. She was not yet a senator when she was just a mom, and she's a business person. And she said they challenged us to run for office, to get out there, to have a voice, to make a difference, because it's through political action that things will happen. Well, the two of us I elbowed her and said, "You're doing it." I didn't want to, and she was saying the same to me. Well, she lost or won, depends on how you want to consider it, but has done a lot to improve the lives of women in Pennsylvania, in her work. And I would say political action, I mean, I hate to admit it, we don't want to do it, but it's where it happens.
Anne?
Yeah, I think the important thing is that, as Ruth was saying and other people have said here, is that we really involve women and young people from the community in finding the solutions to the problems, because we can't decide for them what they need, but they can tell us and we can help them. So we talk about partnerships, and those are just the kind of partnerships that we need to develop. I'm about to launch a new program in North Philadelphia to address teen dating violence with a colleague of mine who started an organization, community member, in honor of her daughter who was murdered by her boyfriend she was age 21. And we're working with youth in North Philadelphia to develop a youth leadership team so they can have a voice around teen dating violence in the community and continue that work into the future. So,
Ruth.
I'd like to raise an issue which might make some people uncomfortable, but racism is a big issue, and it's not a one-way street, it's a two-way street. When I went to Washington in 1994 and I started networking in order to inform the people in government and the neighborhood people about what we'd like to do, I would walk in, I would take a video that had been made in the South Bronx. And what I learned in the South Bronx, I knew we could change the outcomes, but I did not foresee the empowerment factor of giving a woman her record and saying, you weigh yourself, you write your weight on the record, we'll help you if you need that, you test your urine. And you're saying to them, I trust you, and I think you have the intelligence to do it. So that's one way of empowering. But when I would go into these meetings, I would take a film done in the South Bronx with me to inform, because I would walk in and I would say, now I know I'm the wrong color, and I'm from the wrong place, New York. You know, people are crazy in New York. So, but then when they saw the film and they saw the reactions of the families to the care we were given, the race was off the table and my motives were off the table, because why do white people go into black neighborhoods? Mostly it's for population control, and that's not what we were up to. So that's my message on that, and to really engage the people in the community. I went back to see a woman with whom I had made friends, who was the leader in a tenants association in a housing project behind us. And I said to her, when we had been open for about 2 years, and she was in bed dying of breast cancer, but I said to her, Miss Patsy, we haven't had any graffiti and we haven't had any break-ins. And she looked at me and said, I told them, leave it alone. It's our center. And that's what we have to do. We have to make that partnership so that people believe it's their center. And you don't do things they don't want done. You always ask them about that beforehand. I just wanted to add one more thing about replication, because and where the money comes from. If you look at what we're doing, we're taking the silos, the federal silos of Medicaid, Healthy Start, and early Head Start, and we're trying to get the Congress to see that these should be joined together. And right now we're hoping that healthcare reform will give us some opportunities for this.
We need more mentors, more women that look like them or you or whoever it might be. We need to encourage people in the communities, find those leaders. They do that in countries in Africa, and let them be the champions to spread the word. I think we need mentoring.
I just want to follow up with that and share with you a program at Penn, and that is that we have established relationships out in the community and with the high schools to bring young women, really outstanding students from Philadelphia high schools onto the Penn campus. And we have faculty that volunteer their time on Saturday mornings to teach these young women about reproduction and to get them interested in science. And as you know, this is one of President Obama's priorities. And I think we have to really start at a young age, get them engaged, and empower them early, and get them interested in science, medicine, nursing, whatever field. But we do have to serve as mentors and develop leadership skills in our youth. And I think that applies to both girls and boys. I want to thank all of you for your great questions, and I'm sorry if we didn't get to all of them, but I promise you they will be answered on the website. I think that I'd just like to take a minute to summarize what you've heard. And I think if we are going to improve the health of women and ultimately the health of their families, we are going to have to develop very innovative, collaborative models of care, programs like Ruth's, We're going to have to develop partnerships in the community, whether it's through the schools or the churches or community centers. But the only way to make a difference in these communities is to get out there and do the type of research and programs that you heard about today. And lastly, as Marie Savard said, we need to empower women to be responsible for their health and to give them the tools that they need to stay healthy and keep their families healthy. So I want to thank our panelists for this morning's discussion.